Hello and welcome to GenQA's Focus On webinar. We are absolutely delighted to be joined by colleagues today who are going to give us an update on the generation study, the sequencing of 100,000 newborns, which is currently happening across the NHS in England. So we're joined today by Amanda Puccini, who's the Clinical Director of Genomics England, and Professor Emma Baple, who is Professor of Genomic Medicine and the Medical Director in the South West Genomic Laboratory Hub in England. These are the agenda for today. So we're going to get an update, as I say, on the generation study, which is a really great, amazing initiative that is happening across, as I say, the whole of the country in England. Then we're going to hear from my colleague, Dr. Dave Krujin, who's one of the deputy directors at GenQA, who manages and is the lead scientist for the molecular newborn screening external quality assessments, and he's going to give us an update of where the new EQAs are being developed in this field. And then we're going to finalise the end of the webinar and give you an opportunity to ask some questions, and we'll have a live Q&A session with our expert panel. So to be able to facilitate that, please pop your questions, add them into the questions box that hopefully you can see on your screen, and we'll be able to work our way through. So next slide, please. Lovely. So I'm now going to hand over, great pleasure, to Amanda to give us an update on this very exciting programme that's happening. Thank you, Amanda.
Thank you very much, Sandy. We're delighted to be here to be able to share with you some information today about the generation study. We'll talk a bit about how the study came about, but focus as much as we can on what's happening now. The study is live and recruiting. We're starting to get some experience about how this has been looking for sites recruiting and returning results from the study, and a little bit about the outcomes and where we hope we might see this go as we learn from this research study in the next couple of years and beyond. So before we get into details about the study, I think it's always really helpful to understand why was it important to do this? Why was it important to explore this question about genome sequencing in newborns? In general, we estimate that less than 1 in 200 children who are born in the UK have a genetic condition that in particular could be treated, that could be with a particular therapy or a drug or other dietary change, but actually some action that could be taken to help with that condition. And that number is growing as we develop more and learn more about potential therapies for rare genetic conditions. To give you one example and reflect that in the context of the 100,000 Genomes project, I'll tell you a bit about Owen. Owen and his parents both had their genome sequenced as part of the 100,000 Genomes project. He'd had a few years of sort of delays with his development and growth, a number of genetic and other tests that didn't reveal any underlying genetic cause. And through having his genome sequenced in the 100,000 Genomes project, which was driven by his symptoms in this case, not as a screening test, he was found to have a change in a gene that affected his thyroid function. And by knowing that underlying cause, Owen was then able to receive a fairly cheap and simple therapy of thyroid hormone medication to help with that condition. What's particularly interesting about Owen's case is, as many of you may know, we do test for congenital hypothyroidism on the standard newborn blood spot program, but the rare type of thyroid condition that Owen had is one that wouldn't be picked up through that type of test. So his parents really talk about the value of having a diagnosis, but also about what the additional value could have been had they known about this information as early as possible before he started to have problems with his growth and his development. To give another example, in the world of sort of increasing gene therapies, Teddy and Nala are two siblings. There was a story about them a couple of years ago, which is really very challenging, the types of stories that we see often in families that approach genetic services for genetic counseling or for testing, where the older daughter eventually was diagnosed with metachromatic leukodystrophy, which is a very serious life-limiting condition that until very recently did not have a sort of treatment. It was very much supportive management for that condition. But a drug, Libmeldy, was then recently approved in the UK, and it was right around that time that parents were having their elder daughter diagnosed, had already been pregnant with their second daughter, who turned out to also have the same recessive condition. And that timing meant that that younger daughter not having developed any symptoms yet, could receive that newly approved therapy. So obviously you can imagine the mixed emotions for this family. Obviously for their older daughter, she was already too advanced in her symptoms to receive that treatment, but a really hopeful experience for their younger daughter. And again, this just really highlights that for many genetic conditions, timing is really crucial in terms of when we can make an impact. So it's stories like that that have really driven us to think about how we could use genome sequencing in newborns to diagnose a larger number of rare conditions earlier. Now, that's obviously something we want to drive towards as successfully as possible, but we know that once we get into the devil of the detail, it's actually much more complex. And we also need to be thinking about how we can do this at quite a large scale in the NHS and also minimize the potential harms that could also come to babies and families if we didn't do this properly. So the Generation Studies research focus, as I've mentioned, is to sequence the genomes of 100,000 newborns to look for a larger number of earlier onset rare conditions. It's something we're running very much in partnership with the NHS. As Genomics England, we're an organisation funded largely by the Department of Health and Social Care, and that's who's provided the funding for the study. But the recruitment and return of results of families is very much integrated with the NHS, so we work closely with our NHS England and NHS Trust colleagues as part of this process. What's also crucial to note is that this is separate to the existing standard public health blood spot program that has been running very successfully for a number of years. That tests for already 9 or 10, depending on if you're in an area of a running pilot, and has been very successfully taken up by a number of years. Those conditions are very carefully selected, very well studied. We have very good indicators about their outcomes to screen them early as part of standard care. But as a research study, we're trying to think about how we can push those boundaries a bit more widely to learn about a wider range of conditions. This study has a broader remit than just screening for those rare conditions. It's also important that we understand how this approach looks like over time. And that means that parents are also agreeing for their baby's data, genome and health data and samples to be stored in the longer term in our National Genomic Research Library, which is like a large research database that already contains the data from those participants in the 100,000 Genomes project and those that have whole genome sequencing in the Genomic Medicine Service. That data in the longer term can help us understand what are the longer term outcomes of participants, including those that had positive results or false negative or other diagnoses that we might learn about over time. And also where being part of that large database, that data could be very useful for us to understand more about gene disease associations and contribute to the development of new treatments and diagnostics for the NHS. As part of that long-term study, we also want to have a long-term relationship with our participants over time. Initially, that will be parents, but also those children as they get older, a little bit like how we see in other birth cohort studies. And this gives us the opportunity to explore the potential risks, benefits, and broader implications of storing that genome over a lifetime. Are there other questions that we might be able to ask of that genome, potentially if a child then presents with symptoms, or maybe there are some later onset conditions in the future that might be helpful for us to screen for. This isn't anything that we've committed to doing at the moment, but it's very much an exploratory aim for us to be able to continue engaging with participants in the public to see what the appetite and challenges would be for doing things like this. In terms of how this study has been set up, I mentioned already that we've worked very closely with NHS England and the Department of Health and Social Care. That also includes the UK National Screening Committee, which is the body which makes decisions about implementing new screening programs in the UK. Over the last few years and until we've started actively recruiting, we really try to develop this study very closely with members of the public, with patients, with healthcare professionals and researchers. We did that in a number of ways. We started with a national public dialogue that helped us understand what some of the caveats and considerations should be for running a large study like this. And as we got more into the detail, we developed a series of specific working groups to help us think about specific topics that would lead us to think about how we would design the study. And Emma will be getting into more detail on one of those particular areas, which we think will be of interest to this audience, on how we selected the conditions that we would then test for in participants. We've also had the benefit of undertaking a range of user research activities. This isn't like sort of standard qualitative or quantitative academic research, but really allows us to focus on how we can understand parents and healthcare professionals' experiences in quite a rapid time frame to really help us inform the design of the study. It meant that we could put prototypes out of what our materials or messages about the study looked like and think about how parents understood that. Were there things that we needed to change? Was there certain terminologies that we needed to use or avoid to make sure that parents could make an informed decision and that healthcare professionals also understood the nuances of the study effectively, as well as the processes for returning results. So a lot of those engagement and research activities have gone into the study that we are now running. So in terms of where we are, the sections kind of 1 and 2 is really what I've discussed, how we got to that vision and the feasibility of designing the study. We've also, as a research study, had to get approval from a research ethics committee and an approved protocol and materials to make sure that that was robust. We're now at the stage of running this NHS embedded research study, and just some figures here in terms of where we are as of just pulled these last week. We have 20 sites live across 18 NHS trusts in England. We're seeing a significant sort of uptake now in parents being enrolled across those sites, nearing 8,000, and over 5,000 samples taken. That gap is because parents are making a decision to join at an earlier stage in pregnancy, and then samples are taken after the baby is born. The primary sample of which is cord blood, but a secondary sample, if cord blood was missed, might include a heel prick or very rarely an indwelling line sample. We're also seeing that whole process through where then those samples are having genomes sequenced, analyzed through our pipeline, which we'll describe a bit more as well, and returning results to participants. We expect that the vast majority of participants will not have one of the rare conditions that we're testing for in the study. And so they have, again, a carefully worded result that indicates that none of those conditions we screened for were found, but that doesn't mean a clean bill of health. And what does that mean in terms of being a participant in the future? I'll also discuss further as we get into more detail about the number of cases we're seeing where we're finding a prioritized variant, which suggests there could be a condition, but then have a careful manual review step with seconded clinical scientists to make sure that the results that we ultimately return to the NHS and to patients are really robust in terms of being at least likely pathogenic, and where there's good evidence that we have that that's going to link to one of the conditions that we're testing for. I mentioned again, we're live in a number of sites across England. We've really tried to make sure that we're capturing a spread of geographically, urban and rural locations, thinking about the diversity of communities and people who use those hospitals, and maternity and research department performance. We're expecting to open in a few more sites over the next sort of few months, and that those sites then continue to be recruiting at pace for the duration of the study, which is funded until end of March 2027. What's also important, thinking beyond just the recruiting trust view, is again, we have to close the loop with families and return results to them. And particularly where there is a result of a condition that's suspected, those trusts that are involved in recruiting, which are often focused on antenatal services, aren't the same services that would be most appropriate to be involved in returning those results. So to help us close the loop, we've been working really closely with the NHS Genomic Medicine Service Alliances, which are already set up to deliver genomic medicine testing and referral and result pathways in the NHS. So leveraging the expertise that already exists there to help us return those results to the right pediatric expert team. A key role in this process is what we've called regional result coordinators. We have one or two that sit within each of the GMS regions. Often they are either a genetic counselor, nurse, or midwife by background, and supported by other clinical team members within those GMSAs, who are helping to make sure that the results that we have is returned to the right clinical team within that region, and supporting them and the family through that return of result process. This is just to give you a high-level overview of what that participant experience looks like. It's the culmination of a lot of that engagement and design and working group sort of input that we've had. As I mentioned, parents are introduced to this study in pregnancy, and the exact time and process can vary in each trust. We wanted to enable them to define the specifics of the process that would work best for them in the context of their trust. Consent is then recorded before birth because samples are taken so shortly after birth, ideally, as I said, cord blood. And then those samples are sequenced and, as I mentioned, returned back to patients or participants, as well as that longer term nature of them being part of the study, including the ability to withdraw from how their data is being used and processed at any point in time. What's not very evident on this particular slide, but we know is very important for the future of this study, is how we continue to engage those young people, those participants whose genomes have been sequenced as they get older, and ensure that as they approach age 16, we can facilitate them making their own decision to continue to take part in the study. We've developed a range of materials, again, that have had user research input to help make sure that we're being as clear as possible in our messaging to families, helping them to understand the nuances and the benefits and risks. And we've made that available in a range of different ways, whether that's a hard copy information sheet or information on our website, which I'd encourage you to look at if you'd like. That really takes you through the kind of information that parents are making a decision on. And again, as I mentioned, some of the nuances where we've developed, as an example, some keep in mind scenarios that we hope will help to highlight some of the potential uncertainties of taking part in a research study like this. For example, the potential that a result could be a false positive, or where treatment might not be something that happens immediately, but could happen in the subsequent months or years, or is something that needs to be monitored over time. So we want to make sure that although the proportion of families that will be in this situation is very small, that families and parents are thinking about that as part of their decision making and understanding if this is a study that would be appropriate for them. Just very briefly thinking about some of the early learning that we've had from our recruiting sites. We know that a one-size-fits-all approach to recruitment isn't going to work effectively. Each hospital has a slightly different sort of pregnancy journey in terms of how and when parents are coming in for scans, when are they waiting, when are they being seen in the community, when are they coming in for delivery, and that sort of helps to dictate what might be appropriate times to engage with parents about their decision making. We are seeing a high proportion of parents who are self-flagging their own interest in wanting to consent to the study, but we also want to make sure we're focusing on those parents who are pregnant, but also who aren't going to be sort of highlighting their own interest. We want to make sure that we're doing as much as we can to enable equitable access to participation. We know that engagement is essential from both senior staff in trusts, understanding that the study is happening and the impact that could have, as well as on the ground staff. And part of the funding we give to trusts in delivering the study ensures that that goes to additional staff, often research staff members, who are carrying out the more sort of time-consuming aspects of registering and consenting participants, so that that's not falling to sort of existing kind of jobbing clinical midwives who we know are very stretched already. We're also establishing networks with those trusts, which are being very helpful for us to understand what are some of the shared challenges and experiences that we're learning are working very well so far. So we're going to shift focus to really think more about the latter end of this study, less so on recruitment, but more about the conditions we're testing for and how we return results. So with that, I'm going to hand over to Emma to take us through this next section.
Thank you, Amanda. So we thought for this audience, the conditions and the way that the variants are filtered in the genes that are part of the program would be of particular interest. And so the challenge here is there are lots and lots of conditions that we could detect through whole genome sequencing. So it's balancing what we can do with what we should do. And we certainly don't want to look at all of the rare conditions that there are that we could potentially test for. So we needed to hone that down to a specific set of conditions, genes and variants. And although there are principles and criteria that already exist that I'll tell you about in a moment, the decision was taken that those were not really suitable as we move into an era of genomic newborn screening. We needed to take more of a bespoke approach in the context of it, also in the context of a UK-based research program. So some of the things we want to consider as part of that are clinical utility. So whether the test can tell you something meaningful about the condition, the age of onset, treatment and management, and then clinical validity. So whether or not the variant that we're looking at helps to tell you whether or not the condition will manifest or not, and at what age. So next slide, please, Amanda. Thank you. So I said previously that there were already some criteria that exist for screening. So the Wilson and Younger criteria were defined in 1968, and it was an incredibly helpful piece of work that was done at that time, but the authors themselves didn't think it would still be standing in 2025. It was a starting point, and it was to determine what sorts of conditions might be suitable for screening. It was based on the availability of treatment, how important the condition was, and of course, when we're thinking about population level screening, how common the condition is also becomes important. That's less important when we move on to using genomic newborn screening, because we're not using a specific assay for each of those conditions. So you can see here that a number of these points do still stand. So it should be an important health problem, and there should be a suitable test. The test should be acceptable to the population. There's a number of things on here that, again, would be absolutely vital in terms of the National Health Service. So facilities for diagnosis and treatment should be available, and it should be a continuing process. So next slide, please, Amanda. So the guiding principles for coming up with the principles that would underline this were that they should be co-developed. So we should be considering what the public and those with lived experience of rare conditions think about. We should also be going to experts, so clinical, scientific and ethical experts, to ensure we can be confident in the framework and its validation. It should be transparent, so we want to be open about the rationale behind any decisions that have been made and why conditions have been selected to be included in the programme, with opportunities for people to ask questions about that. There should be robust evidence, and we need to be able to achieve a balance between those clinical, scientific and ethical aims. And again, we wanted to make it flexible because obviously we learn more and more about rare genetic conditions all the time, both in terms of new disease gene identifications, but also in terms of what we learn about penetrance of conditions and other elements that might impact how you would think about a screening program. So we need to be able to have that flexibility. Next slide, please. So just to kind of go back to the actual approach that was been taken, because I think sometimes people think about whole genome sequencing in itself as being being a test, when in fact it's the technology we use to take out to do whatever analysis or test we want to do. So in this case, we're looking at a gene panel. That gene panel has been designed for the purposes of screening, and it's only the genes and variants that have been selected to be analysed will come through for the clinical scientists to look at. So we call that a virtual panel, and on top of even that virtual panel, from a gene perspective, we are only looking at specific variants. Next slide, please. So in terms of the principles themselves, we actually started off with quite a number of principles, and those got honed down to 4 core principles, and the conditions framework group that were involved in bringing those together had broad representation from different medical specialties that would be where the conditions would be important. So for example, we had metabolic representation, we had representation from cardiology, genetics. Sarah Wynne, who is the chief executive of Unique, and colleagues from Genetic Alliance also took part in this, as well as having some really excellent patient representation, actually, that helped us to get the wording appropriate on some of the principles, and I'll go through those now. Essentially, principle A, there is strong evidence that the genetic variant or variants cause the condition, and it can be reliably detected. Ideally, there would also be a non-genetic confirmatory test for the conditions, and we'll talk a little bit more about the conditions in a moment, but there are a small number of conditions that are on the final list for which there isn't a confirmatory test, but that was an important part of the assessment process. Principle B, we're really here thinking about penetrance, and that's obviously absolutely crucial in genetic conditions, but Principle B is a high proportion of individuals who have the genetic variant or variant would be expected to have symptoms that would have a debilitating impact on the quality of life if left undiagnosed. And that word debilitating, we had a lot of debate about, because obviously what people consider to be a significant impact or an impact on quality of life can be variable from person to person. So where possible, QALYs were taken into consideration, but for many rare genetic conditions, we don't have that sort of information. So testament from those who have lived experience of the condition was also taken into consideration where possible. And then principle C, early or pre-symptomatic intervention for the condition has been shown to lead substantially improved outcomes in children compared to intervention after the onset of symptoms. And in general, we took 5 years old to be the sort of age cutoff, but there's some flexibility because again, we need to be thinking about the impact of a particular treatment and the age of onset of that condition and balancing all of those things against each other. And then again, coming back to the fact that this is being undertaken in partnership with the National Health Service, Principle D is that conditions screened for are only those where interventions are equitably accessible for all. Next slide, please, Amanda. So just an example of how the principles were used, and this work was undertaken by David Bick and Katrina, who was working as part of the Genomics England team, and they did a really excellent job of going through many hundreds of conditions and looking at those against the principles and talking to clinical experts alongside this. And they used an SOP that was designed specifically for the programme and that considered the principles. So this example is ALDH7A1 related pyridoxine responsive epilepsy, and children who have this condition get severe seizures very early on in life. And pyridoxine, which is a relatively simple, effectively vitamin treatment, can be given, and that can help to essentially really control those seizures. Children who don't receive that have very poor seizure control and go on to have significant developmental impairment. So I've chosen a very easy example, really, in terms of meeting the principles coming down here, but it gives you an idea of how these conditions and genes were assessed. So variants cause the condition, and one of the tools that was used was the excellent ClinGen gene disease clinical validity curation, but for some less common conditions that wasn't available and other sources were used. Confirmatory test being available, and often gene reviews is an excellent source of information for that if there's a gene reviews available, but again, there are other sources. The condition significantly impacts quality of life. I've obviously given you the information we know about that disorder, and we have quite good information about pyridoxine responsive epilepsy as compared to other conditions. And then the treatment is absolutely paid for by the NHS. It's a relatively cheap treatment, actually. Next slide, please. So I'll go through the variant prioritization strategy. There's a lot more detail on this that you can find on bioRxiv. So the bioinformatics team involved in Genomics England have put together a manuscript that describes this in a bit more detail, but in summary, essentially, the aim of the pipeline was to prioritize variants in the genes and conditions that have been selected to reach pathogenic or likely pathogenic classification. So only pathogenic or likely pathogenic variants would be fed back, because we need to remember that we are thinking about children who may have no clinical features of the condition. So inclusion lists were used to source high quality variants, and that was from ClinVar. There's a purchase list from QIAGEN, and then the clinical variant ARC, which is where the whole genome sequencing from 100,000 Genomes project and the GMS is deposited, as well as internally curated inclusion lists and lists that came from some of the NHS genomic laboratories. I won't go through the variant filtering in detail because you can see it on the screen there, but as expected, it thinks about things like allele frequency. And then when we're not thinking about variants that have already been reported and for whom we can fairly reliably assess their pathogenicity up front, then where we have genes where loss of function is the mechanism, we also wanted to ensure that predicted loss of function variants were pulled through, and those were in either the main or the canonical transcript. And again, there was an internal allele frequency for biallelic and monoallelic genes, and nomad allele frequency was considered as part of that. And then there was an exclusion list of variants, so where we have common technical artifacts where variant calls were unreliable. There is a non-newborn phenotype related to the variant, or the variants were associated with lower penetrance or a milder phenotype. There is only the newborn sample is sequenced, so the parent samples aren't sequenced. So although we want them to match the expected inheritance mode, it's only possible to do that using read-based phasing in this pipeline. And then the variants are reviewed by experienced NHS clinical scientists who will look at those variants and assess their quality and their pathogenicity. And that's why you see that dropping down from just over 4% to 0.6%. Anything you want to add to that, Amanda? No.
No, that's perfect.
Yeah. And I think after that process, you have an internal MDT at Genomics England, don't you, where the clinical scientists present that information. So for a second sense check in this early stage of the programme, because we want to make sure that that is absolutely being done in the safest possible way. So we've got 489 gene condition pairs, so more than one gene causes each condition. So that comes to 207 conditions that have been included and considered category 1 following the review process. And I already mentioned only pathogenic and likely pathogenic variants will be reported, but currently that accounts for about 84,000 pathogenic and likely pathogenic variants that would be assessed as part of the programme. The list is not set in stone. We talked about that flexibility, and it's possible that conditions will be added or removed in response to emerging research during the programme. And when those changes are made, they would be highlighted in an amended published list. And you can download the list from the Genomics England website if you're interested in seeing those conditions. Next slide, please. So just wanted to quickly go through the process by which the NHS clinical assurance was involved in determining the conditions, but also the pathways that would be involved in the management of these children once they'd been identified as having a condition suspected result. So the NHS clinical assurance group role was to ensure that for every condition that would potentially be identified in the programme, there were appropriate services and pathways in place, and that those pathways would be willing to accept babies identified through the study. And Genomics England and Amanda and team worked very hard with the national specialty advisors and clinical leads and lead commissioners of the clinical reference groups to make sure that they had the right people to look at each of those condition gene pairs. And there was the suitable expertise around the UK to do all of those things. And then those clinical experts were able to highlight additional points that were important for the clinical assurance group to consider. For example, some of these conditions are very rare, and we need to consider capacity of of those clinical pathways to manage children who may be suspected to have the disorder. And there was also a subgroup that looked at the treatments and interventions to inform the clinical assurance group on specific issues relating to availability and commissioning of treatments. Next slide, please. So in terms of communicating the results, obviously the condition suspected results need to be managed very, very carefully. We're giving families information that is likely to be upsetting and difficult to digest. We're only expecting 1% of babies to have a condition suspected result, so that should equate to about 1,000 children throughout the programme. And that initial communication is done by phone, and it's currently about a couple of months after birth, with the aim being to reduce that as the programme beds in and we have more experience. That's done by an NHS specialist with expertise in the condition, and they then arrange an appointment for the child and their parents to have the confirmatory non-genetic testing and confirmation of the genetic findings as well, and then to receive that further care if needed. Majority of the children, particularly in the early stages of this programme, wouldn't be expected to be additional patients, because most of those who would be presenting acutely unwell in the newborn period are likely to be already within the NHS services prior to the research study results being returned, at least initially in these early stages of the programme. And others would of course likely to become part of be seen within the NHS at a later stage down that diagnostic journey. In terms of the no condition suspected result, that's majority of the children in the programme, and that's by email or letter, and that's currently a few months after birth. And that piece of work is done by the Genomics England team, who also make sure that the GP is aware that the child was part of the programme. And they are reminded at this stage that although their child doesn't have a condition suspected result, they are part of the ongoing generation study programme. So their data will be available within the research environment to ensure that we can learn everything that we can about not only those children diagnosed, but those who perhaps were not diagnosed and go on and develop a rare condition, and the other things Amanda mentioned that would be potentially relevant when thinking about rolling out a newborn screening program using genomics. And then sample failure and no results are also communicated by email or letter. Next slide, please. So these are the results that have been returned to the NHS so far. Amanda, do you want to talk a little bit about those?
Yes, sure. So this is just a snapshot of the types of conditions that we've seen amongst the 23 results that we've sent back to the NHS. You can see that obviously, as we'd expect, we are looking for the same conditions that are already on the blood spot test, and we are seeing some of those. And when that happens, the regional result coordinators sitting in each Genomic Medicine Service Alliance will first check with the relevant screening lab linked to where that baby was born to verify and validate the results that they will have already had at that point, probably from the standard blood spot test. That's important both for us to ensure that there's kind of concordance, which we expect to be the case the vast majority of the time, but also so that we can then identify if that child has already been contacted by a specialist team, and just make sure that it's that same specialist team that are informed about the study result, so we're not creating additional unnecessary confusion for families being contacted by two different people about two very similar things. The majority of conditions we've seen have been a range of some of those other conditions that have met those principles that Emma's described. They range in terms of their level of rarity, in terms of the specialty that tends to be the primary specialty, making initial contact and being responsible for talking through the treatment and next steps in testing for that family. So this has been particularly helpful because we've been really able to learn from how that result return process has gone from the result coordinator and the clinical team and the family's point of view. And so we've been trying to take some of those learnings from that to think about if we need to make any course corrections in how we've planned to return results to date. We're also starting to gather crucial information about the results of those confirmatory genetic and non-genetic tests. That really helps us to understand whether the case that we've returned is indeed a true positive or a false positive. We will expect a small number of those, or potentially somewhere in between if those confirmatory test results, particularly say a biochemical result, is uncertain or inconclusive, then it's also really important that we follow up carefully with those families. Emma, you might want to share a bit more also about what the experience has been like in the Southwest in particular with the few cases that we've had.
I think it's been very much a learning process. We've learned about the way that the results, the genetic confirmatory results need to be worded, because obviously this is that we're looking at children who may not have manifested any features of the condition at the time that the genetic findings are confirmed in the laboratory. And just that kind of experience of dealing with children who've had conditions that have been detected within specialties that perhaps have less experience of newborn screening traditionally. But altogether, I think so far things have been going really very well. Everything's been managed very carefully, and there's so many safety checks at each stage of the process to make sure that the clinicians involved in that process, the professionals involved, and the families all feel that they have all the support that they need. So I wasn't going to talk too much about this because Amanda has just gone through quite a few of those bits of things just to highlight really uncertainties that we would expect to see actually in all forms of screening. So the possibility of a false positive, which when you're thinking about research, you would intuitively think there may be a slightly higher chance of that occurring. An unclear diagnosis, so we're not able to, the follow-up test can't confirm or disprove the diagnosis. Sometimes it takes a bit longer to confirm a diagnosis and lots of tests need to be done. And sometimes when we are that where we're not sure about the patient's symptoms, and they may have no symptoms, it will be difficult to know whether or not they will have those symptoms and what age they might have them. And then the effects on the family. So obviously in genetic conditions, the results may be relevant to more than just the immediate family. I'm going to, oh, you've taken that one out anyway, so that's excellent. So thinking about the genomic research report, this, again, the wording, a lot of thought went into the wording of this, because we're not, we haven't confirmed a genetic condition. We have said that a condition is suspected based on the genetic findings. And so that's very important, particularly when you're thinking about ensuring that the clinicians and the family are very clear about what the results from the study have shown. It shows the information about the variants and who's reviewed those variants. Next slide, please. In terms of the confirmatory test pathway, lots of work went on at Genomics England to design a pathway for and information to accompany that for every single condition and gene that is part of the program. And so each condition has a unique confirmatory test, and the intervention is clearly defined for those specialist teams receiving a result. And the support from the results coordinators that Amanda has just talked about is crucial in ensuring that the clinicians feel supported through all of this process. Next slide, please. The condition information sheet, I think, is also really important. So this is primarily aimed at parents and for the period after which they're told that their child has this condition suspected result, which, as I mentioned before, is a really difficult time for families. And this is a really useful piece of information, just-in-time resource that they can have. And it's also helpful because if they're going to see their GP or other healthcare providers in the time between them receiving that phone call and them being seen in the clinic, this information is there for them and aids communication. Next slide, please. And again, there are very clear guidelines for the specialist clinician who's contacting the family that also act as that just-in-time resource. It's not a prescriptive process, but it does provide that support for them. As I mentioned, not all of the specialties and clinicians involved in this program will have had experience of traditional newborn screening, so it's important that they feel supported, and it includes important insights about communication challenges that may arise. The diagnostic outcome form is clearly absolutely crucial, and that is an electronic form that is completed by the clinical team that are looking after the child, but again, the results coordinators are there to support those clinicians throughout all of that process. It's, as I said, this is absolutely crucial that we have that information, because otherwise we won't be able to learn about the impact of the study. Next slide, please. Back to you, Amanda.
Thank you. So hopefully we've given you a good picture of what that journey looks like for participants in the study, particularly on how we then are returning results and the kind of support package that goes to those specialist teams and to families. I'm just going to end with sort of 3 E areas: ethics, education, and evaluation, that kind of wrap around the study before we finish. Of course, I think the study like this and the sensitive and complex nature of sequencing newborns raises a number of questions, and this is something that we aim to tackle both in the design stage. We expect some of these questions to continue to arise and help us think about how to deal with them, particularly around return of results throughout the duration of the study, and also beyond, where those participants have had their results, but thinking about that ongoing data storage and use, and how we maintain a relationship with participants so that we have that also that value that we're giving back to them over time, as well as the support that they give to us in entrusting us with that data. A lot of the sort of elements of the study also raise the question about how can we make sure that the workforce are prepared to deliver the study, but also to help to prepare them for what a future world could look like if we did bring genomics more into newborn screening. And that includes a range of healthcare professional groups, from midwives to pediatricians, not just genetic specialists, but including those that also work in labs, as well as thinking about sort of broader healthcare professional groups like GPs and health visitors that are supporting families during this time. So that's led us to develop a number of specific resources that can help support study teams in enabling consent, as well as some of the resources we've shared to support giving results. We've developed, for example, this shot on the right of the slide are what we call kind of informed choice cards, where we've developed some scenarios that help those people involved in consenting families to think about some of the challenges involved in enabling consent to a study that has this sort of long-term genomic complex nature. And we've also linked in with resources that are already available, like GeneNotes and some of the other work that the Genomics Education Program has been doing to start to upskill the workforce in genomic healthcare. And then finally, in order to run a study like this, we have to also be thinking about how we're going to evaluate the process and impact and outcomes of that study over time. So that's, again, something we've thought about carefully from the beginning in terms of defining what our study's research questions would be, but also something that we're working with an external evaluation group with expertise in behavioral science, implementation science, health economics, to help us to answer those research questions. So they're using a number of different methods, surveys, interviews, other forms of data collection, to help us understand whether this type of approach is feasible in the NHS at scale, acceptable to the staff and families and public that are helping us to deliver this, understanding the impact, both positive and negative, of the program and its results, the cost effectiveness, some of these questions which we're more likely to understand more about in a longer period of time, and just generally the kind of experiences and attitudes to this type of approach to help inform if the evidence indicates that this is something that we should be thinking about in the future. So to finish, at the end of the study, at the end of March 2027, we hope that we will have sequenced the genomes of up to 100,000 newborns in the UK, and that has given us the grounding to establish an evidence base on what genome sequencing means for the future. And also that we will have provided the data. Again, we'll have had a degree of that by March 2027, but also something that we'll expect to look at over time to help evaluate what the study's outcomes were and inform future policy working with the National Screening Committee and the NHS. We think that in general, this does raise a range of opportunities, as well as the number of challenges that we've talked about working through, not just about potentially expanding newborn screening for the benefit of children and their families, but also doing this as a research study gives us a really great opportunity to do this in a way where we can understand and evaluate the impact that something like this has on families and the health system before we just think about going and doing something. So it allows us to monitor and evaluate in a careful way, as well as exploring the ethical and societal questions, as I mentioned, about the potential for that genome use in the longer term, and thinking about the impact and change on the NHS workforce, that through these changes we can think about how we're developing the workforce and the wider system to facilitate some of those future changes that we might then expect. Thank you for listening. I think I'm handing back over to one final speaker before we have time for questions, but we've also put our contact details there and where you can find out more information after today as well.
That is great. Thank you so much, Amanda and Emma. What a real rich presentation that was, actually full details. And as I kept coming up with questions, the next slide answered the question. So absolutely spot on. Thank you very much indeed. Dave, before we go into the live Q&A, and I would encourage everyone to put some questions in for us to answer. There's a couple in there already. Dave, can I come to you to give us an update on what's happening in the EQA side of newborn screening, please?
Yeah, of course. So this is just a really brief, it's a plug for our EQH really, before we get on to the Q&A session. So we're just going back a step really to our existing newborn screening and the EQAs, the molecular EQAs that we offer for that. So it's to show what we do at the moment. We've got a couple of EQAs where we're looking at the sort of primary screening test, which is on the DNAs, so whether the primary tests are on DNA, so that would be SCID, looking at track levels, SMA looking for the common SMN1 deletion, and then we've got a couple of EQAs which are kind of the second line tests where we're doing the confirmatory test for CF and for MCAD deficiency, and those are all on dried blood spot samples, so we send out dried blood spots. We have 4 distributions per year, 2 samples per distribution, so for each of those EQAs you could have 8 samples per year. and you can use any relevant methodology for those, and also use any existing laboratory test that you use routinely. That's all fine. 4 to 5 weeks to submit your results. We try and make it as easy as possible because it's a fairly frequent EQA, so we have a pro forma available, so you don't have to submit a lab report. But we are thinking ahead a bit as well. So if we go on to the next slide, we have been approached already by a couple of newborn sequencing projects from around the world, inquiring whether we've got anything available, any EQA available for newborn sequencing. We don't yet. We are thinking about it though. Sandy's been in discussion with the International Consortium on Newborn Sequencing. So having a few discussions with them about what we might be able to offer in the future. Obviously, we're going to need slightly different samples. We're going to have to take account of different reporting algorithms. It might be that different areas of the world focus on different disorders, so we'll have to take that into account as well. But we are considering some kind of pilot EQA in the near future. But we're definitely open to discussion about that. So if anybody would like to get into a discussion with us about what they would like, because we do like to get EQA early into the process, so it's accounted for in the process. So I think that's all I was going to say, and then we'll go on to the Q&A.
Thank you, Dave. That's great, and it's exciting times when we've got new developments to come along. Thank you very much. So it's your chance now to ask the panel questions around the generation study, the ethics, anything, or the EQA provision, or even offer to help join our expert advisory group to advise on developing the newborn EQAs. So a couple of questions coming in. I guess, Amanda and Emma, it's more a practical thing, as in you're saying that the numbers are increasing and the gap of results is getting wider, but that's because you're recruiting parents earlier on in the pathway. So when does those discussions start? Is it how early in the sort of the gestational period does that discussion kick off?
Yeah. So although it varies amongst sites, our steer has been that kind of 20 weeks onwards is most optimal for parents, because at that point they'll have had their 20-week sort of growth and antenatal scan and start to shift towards thinking about baby post-pregnancy as opposed to being pregnant. Some are approaching parents sort of more around the 30-36 week mark based on a sort of later appointment they might have. And rarely it might be that some parents are expressing their own interest quite early, but it tends to be more in the later stages of pregnancy.
Okay, that's interesting. Thank you. I guess in time you may expect parents to ask about it, because we know there's a lot of what do we call them, Google patients who come along, particularly in inherited disease, come along with their own idea, please can I have this test? So is that something that you are preparing for, that on at the earlier scans, like 12 weeks or so, actually being able to have that conversation as well?
Yeah, so I mean that speaks to where I think how important it is that it's not just the study staff delivering those consent conversations that know about the study, but the wider sort of antenatal unit at least have to have some awareness, so that if they're approached, they don't necessarily have to give a huge amount of time that they probably don't have, but they can at least say, okay, I know that this is a study running in our hospital and I can direct you to our research team or to our website, where we've developed a kind of simple registry or interest form, so that parents, it's not a route to fully consenting, but it allows parents to say, I'm delivering in this hospital, I'm interested in taking part, and then the research team can work through and connect with them.
Great, thank you. It's about, thinking about the wider system, isn't it?
Yes.
One question here, something more practical and logical. As newborn screening is currently happening, through the Guthrie blood spot cards, could we use that as a source of sample going forward?
It's possible, yes. So the reason why we landed on cord blood is we did a early, before we started the main study, sample feasibility study to look at sort of operationally, how could we get the right sort of sample and what could give us a sufficient quality of DNA. And the blood spot card didn't do as great really at giving us a good quality DNA to do that whole genome sequence. But that's kind of one of the interesting questions about whether that could change over time as technology changes, or whether in general we need to think about a broader shift in the types of samples we take. And there's obviously pros and cons to both and at scale, I think.
Great.
Can I ask a question about that?
Go for it.
So obviously we have existing newborn screening schemes, so you mentioned those, and the UK doesn't have that many, but other countries have, you know, quite a lot more. Do you envisage this in the future as something that would be an addition to those existing newborn screening tests, or I mean, there might be new tests like proteomics or metabolomics? Or...
I think definitely we're seeing this as an addition rather than a replacement of, and that's because there's lots of ways in which the current testing process actually works really well or is always going to be more sensitive. Congenital hypothyroidism, again, being a good example. Often the causes aren't like monogenic. So I think it's about how we see the integration of genomics alongside those other tests, which might also make those few blood spots very precious if we have to think about different assays. But I don't think we'd see it as fully replacing what we have.
Do you mind if I add something on to that?
Yeah.
So for me, I guess the beauty of being able to use genomics as a supplementary assay on top of the current newborn screening is that obviously with current newborn screening we're restricted to a certain number of conditions, and how common the condition is in the population is an important element of the way that screening programs have been set up, not just for newborn screening but across all sorts of different types of screening that we have. What using whole genome sequencing or some sort of genomic approach allows you to do is to essentially put that aside, so you could think about a disorder that may not you may not have a child who's diagnosed with that even every year in the United Kingdom, but that doesn't preclude you from including it in the test. And it means that as we have a very diverse population in the UK, which I think we should be very proud of, but that means that when we think about how common conditions are, we are not able to provide such an equitable approach to screening across the whole of the population. And this gets round a lot of those issues. So for me, that's probably one of the most exciting parts of this.
Thanks, Emma. Dave, can you come up with the other questions? Is the chat's just dropped off my screen? I think there was one about turnaround times and one about hearing loss pathways.
How long does it usually take from sampling to report for this testing?
Yeah.
Or is that very dependent on the follow-up testing?
So not the follow-up testing will, I guess, have its own sort of turnaround time, and that's something where we wanted to make sure could happen in theory quite quickly. But in terms of for us returning the result from the genomic sequence, we are, because it's still relatively early, we are seeing fluctuations. So we're wanting to manage participants' expectations very carefully. So our materials broadly say within a few months. Of late, with the condition suspected results we found, we've been able to return them within 1 to 2 months, which is great. We want to get that down to 2 weeks. And similarly for the no condition suspected results. But if that remained a little bit longer, that's obviously slightly less of a priority than the quick turnaround time we want to focus on for when we think we have a condition.
Yeah, I've got another one. It's how do you handle novel or pathogenic or likely pathogenic variants which have been detected? But also, I guess some conditions you'll always be seeing sort of new variants you haven't seen before, and that I don't know if you've included disorders in the panel that you've got where there can be a whole spectrum right from infantile childhood right up to adult, and you might not be able to tell that from the genotype or even from the confirmatory test, I guess. So how would you deal with those?
Emma, do you want to speak to that? Because those were some of the discussions that came up when we were choosing conditions, how we deal with some that have variable ages of onset.
I guess one thing we should think about is that applies to the current newborn screening also.
Definitely.
So it applies to all of the screening that's done worldwide for newborns. It's essentially trying to balance those things, isn't it? It's trying to balance what we know about a disorder, what we know about the age of that it might manifest, what we know about the particular variants that we are including in the program, and how we analyze and interpret those. And that's why the clinical scientist involvement in that process is so important. But effectively, when we were going through the conditions, the penetrance was an age of onset was a clearly important element of consideration, because there are some disorders where we know that they can manifest very early in life, but they can also manifest much more variably throughout life, and weighing that up against what the treatment might look like, how you might deal with the communication issues for the parents around all of that were all important elements of deciding those things.
Great, thank you.
Can I get another one in?
Go on.
We've got
one last question now.
Okay, this one's a good one. Although participants can withdraw at 16, are there potentially difficult ethical questions arising from having already done some genome analysis without the consent of that particular individual?
Yes, that's something that has come up a lot as we were designing the study. And again, I think that's where it's helpful for us to think about the sort of, obviously we're not the first ones in terms of a precedent to be testing either in a clinical or in a research setting, doing some kind of test or intervention on children where the parents are ultimately making that decision on their behalf. So that in itself isn't new. But what that has made sure we need to think about is how do we make sure we're balancing the benefits and risks, the potential benefits to the child if we were to find a rare condition that we think could be of benefit to them, and how we mitigate against the risks of keeping that data stored and used very safely in very specific ways until we reach that point where then that child is making that decision themselves. So, and in the UK in particular, I think we've got lots of really great experience with long-term birth cohort studies in Bradford and Bristol, and so learning a lot from them about how have they navigated some of these studies that have also involved different types of investigations and how they keep those relationships with participants over time.
Great, thank you very much. So it just left to me to thank Amanda, Emma and Dave for a fantastic session. Thank you very much indeed. Thank you for those of you who have attended. You will get sent a survey shortly to ask for feedback, and we really appreciate some feedback that we receive because we can shape these focus on webinars to deliver what you would like to hear. So please do, I encourage you to complete them. The good news is the webinar has been recorded and will be available on the GenQA YouTube channel, so very easy just to link up and subscribe. So please do pass that information on to colleagues if you think they would be interested. And also you'll get a participation certificate sent to you. So we're constantly developing and delivering these focus on webinars, so please watch the newsletter and sign up so you know what's coming along next. So thank you very much for joining us. Goodbye.
Thanks for having us. Bye.